Well, hello, everybody. Welcome today to our program entitled Supersaturated Oxygen, the Next Frontier in ST Segment Elevation Myocardial Infarction Treatment. I'm Greg Stone, an interventional cardiologist from the Mount Sinai Medical Center in New York City, where I serve as the Director for Academic Affairs for the Heart Health System at Mount Sinai. And today it's my pleasure to be joined by Dr. Bob Kloner. Bob, let you introduce yourself.
I'm Bob Kloner. I'm a cardiologist and professor of medicine at the Keck School of Medicine at USC and chief science officer at the Huntington Medical Research Institute in Pasadena.
Great. So today we're going to talk about some of the challenges that we still experience every day when treating patients with ST segment elevation myocardial infarction, look at some of the underlying pathophysiology leading to what creates large infarcts and heart failure in ST segment elevation MI, and then look at some of the newer therapies, in particular supersaturated oxygen, that may prove of benefit for some high-risk patients that continue to have very large infarcts. So what we'd like to do is start out with 3 polling questions to kind of assess everybody's current understanding of some of these central issues that we're going to be discussing in this webinar. So I'll start with the first question. And so please answer this on your computers. Infarct size is strongly associated with heart failure and hospitalization. This is after ST segment elevation MI. Do you A, strongly agree, B, agree, C, somewhat disagree, or D, strongly disagree? So please answer now. Okay, Bob, would you like to address this question?
Which of the following is true about microvascular obstruction in patients with acute myocardial infarction? A, it is associated with large infarct size and a worse prognosis. B, it occurs infrequently. C, it is caused only by distal thromboemboli. D, it is caused only by reperfusion injury. Or E, it is inconsequential. And here's the next question. Which of these therapies have been demonstrated clinically to consistently reduce infarct size in acute myocardial infarction? A, primary PCI, B, supersaturated oxygen, SSO2, C, post-conditioning, D, hypothermia, E, A and B, or F, A and C.
Okay, so now we're going to talk about where we are today with the treatment of ST segment elevation and myocardial infarction and what some of the limitations are and how we might overcome those limitations with newer therapies such as supersaturated oxygen. So while you're listening to Dr. Kloner and I describe some of the historical issues and the progress that's been made, I'm sure many questions are going to come up in your mind. And please use the remote system to enter those questions as you think of them. You can also enter them later, but either way, during the Q&A session, we'll try to get to as many of the questions as possible. All right, so today we're talking about ST segment elevation MI, and we've actually made tremendous progress over the last 3 to 4 decades at treating these patients. And really, more than anything, it was the introduction of the reperfusion era, first with fibrinolytic therapy and then primary PCI, which has made the greatest gains by being able to, again, reperfuse the thrombotically occluded coronary artery, the cause of most cases of AMI. We're able to stop or abort the infarct by getting the artery open. There are independent effects of enhancing electrophysiologic stability, decreasing infarct size, et cetera. And all of that leads to an improved prognosis. So we've learned that minutes matter and that to be able to most effectively treat patients with STEMI and to have the lowest amount of heart failure and mortality, we have to get that artery open up early. And patients on average come to the emergency room at about 90 minutes after the onset of STEMI. And that really has not changed very much in the last several decades. So the whole medical system, the enterprise, has been really focused on decreasing door to balloon times from hospital arrival to being able to open up the infarct artery. And we've made really tremendous advances at reducing door-to-balloon times, which were running well over 2 hours in most medical centers, to now under 1 hour at most hospitals in the United States. And for many, many years, this was associated with reducing mortality in patients with STEMI. But over the last 10 years or so, we've really stalled. Despite the fact that door-to-balloon times have continued to get so much shorter, mortality has continued to stay about the same. And in addition, we have another problem, and that's heart failure.
So this slide looks at heart failure after acute MI and PCI. And there's no question that with in-hospital PCI shown in the red, there's a lower incidence of heart failure compared to no PCI shown in blue. But even with PCI in hospital, notice that new heart failure occurred in 20% of patients out at 72 months. So this means that we have develop other therapies to further reduce myocardial infarct size, save myocardial cells, and to try to further reduce heart failure after MI.
So what I can tell you, Bob, as an interventional cardiologist, it can be very frustrating because we apparently get the infarct artery open in 85 to 90% of cases. The epicardial coronary artery, we can restore normal TIMI3 flow. And this clearly leads to improved outcomes, but we often don't salvage as much myocardium as we'd like. And that leads to patients still having large myocardial infarcts and this frequency of heart failure that you just described. And of course, it's additive for patients having multiple myocardial infarctions despite our best efforts. So what's the disconnect? How can we get the infarct artery open in, let's say, 9 out of 10 patients adequately in a reasonably timely fashion, but we still end up with large infarcts? Why is that happening?
Those are really great questions, Greg. And I think one of the problems is that we're addressing infarct size to some extent, but we're also not addressing what is happening downstream to the microvasculature. And I'd like to say a few words about infarct size and microvascular obstruction and SSO2. So primary PCI reopens the epicardial coronary arteries of patients having ST elevation MI, but does not address microvascular obstruction, which has been correlated with poorer outcomes, death, heart failure, and adverse left ventricular remodeling. 90% of myocardial blood flow is supplied by capillary microcirculation. And during an MI, not only are there damages to the cardiac muscle cells, but there's also injury that occurs to the small blood vessels, including the endothelium of capillaries as well. And this is an issue that has not been adequately addressed. Now, this slide shows representative transmural heart slices from an experimental animal model of myocardial infarction that was subjected to 3 hours of coronary artery occlusion and 3 hours of reperfusion. Now, at the end of the reperfusion phase, a fluorescent dye called thioflavin S is injected into the vasculature. The dye circulates and it stains endothelial cells receiving blood flow, and it fails to stain areas of reduced flow when viewed under ultraviolet light. You can observe here the yellow-green fluorescent areas that receive flow during reperfusion, and that's shown on these transverse heart slices. And you can also observe these dark non-fluorescent zones that are pointed out by the red arrows. Now, these perfusion defects represent areas of microvascular obstruction or no reflow. And this same phenomena is observed in humans. It can be visualized by magnetic resonance imaging with contrast and is seen upwards of 30 to 60% in humans with myocardial infarctions that are ST elevation MIs. Now, what's the pathology within these zones of microvascular obstruction? Here is an electron micrograph of a normal non-ischemic capillary within the myocardium, taken from some work that I did with Dr. Robert Jennings back in 1974 and published in the Journal of Clinical Investigation. Here, the endothelium appears thin and lacy. It's not swollen. There's numerous penicytotic vesicles, as shown by the P in the arrowhead. There's also a red blood cell, RBC, which is seen in the lumen of the vessel. That's normal, not ischemic. Now, in contrast, here's an electron micrograph showing a capillary taken from a zone of no reflow from an animal model, subjected to 90 minutes of coronary occlusion and reperfusion. Now, when you look at the endothelial cells, the penicytotic vesicles are gone. The lumen is clogged with swollen endothelial protrusions called blebs that appear to be blocking blood flow in the capillary, as shown by the red arrows. Here's a schematic showing ultrastructural features that have been described within areas of no reflow. If we start on the left, we've already mentioned these endothelial blebs. There's also areas of regional endothelial swelling. There may be endothelial gaps with red blood cells that are extravasated outside of the capillary. There may be platelet and neutrophil plugs. There may be areas of the capillary that appear compressed by swollen myocardial cells on either side of the capillary. In addition, there are the presence of microemboli, which are even more common in the human situation, where you have thrombi and microemboli going distally after PCI. So there's numerous reasons to get no reflow or microvascular obstruction. Now, there have been numerous studies over the last several decades to try to develop adjunctive therapy to administer along with reperfusion therapy, that is primary PCI or thrombolysis, to further try to reduce the size of myocardial infarction. And as Greg has pointed out in many papers, the larger the infarct, the more likely you're going to have clinical difficulties, including things like heart failure and death. There have been many failures when drugs were tested in clinical trials, even though they may have shown some benefit in experimental preclinical studies. Here are some that we listed in a review that appeared in JACC. Drugs that failed to reduce infarct size in clinical trials included agents to prevent leukocyte adherence to the endothelium, a sodium hydrogen exchange inhibitor, Calderat, and an intracellular calcium handling modulator, Nicorandol, a potassium channel opener and vasodilator, GIK or glucose insulin potassium, a delta protein kinase inhibitor, erythropoietin, and many others. So there have been a lot of failures, and some have referred to this as sort of the graveyard. However, there is hope, and certain agents show promise in both experimental and clinical studies. One of these is supersaturated oxygen therapy for ST elevation MI, which is FDA approved to treat anterior MI patients within 6 hours of symptom onset. This system withdraws blood in this slide from the femoral artery, then supersaturates the blood with oxygen. And then this blood is delivered, in this case, to the left main coronary artery, delivering oxygen levels with PO2s of 700 to 1,000 millimeters of mercury to treat the ischemic myocardium. Here is data from work by Dr. Richard Spears and Dr. Vanderheide and others in a pig model of 1 hour of coronary artery occlusion and 3 hours of reperfusion. These are transverse left ventricular slices of the left ventricle incubated in triphenyltetrazolium chloride, or TTC, which is a substance that is a histochemical stain. Viable myocardial cells stain brick red, and myocardial infarcts do not stain, and they appear pale white or yellow. So on the left here is a control pig showing this transverse heart slice, and it shows a very sizable myocardial infarct, as shown in the yellow box on the left. On the right is a pig that was treated with supersaturated oxygen therapy. And here, the myocardial infarct appears very small and very patchy, as shown on the right. Now, SSO2 also improved the ultrastructural appearance of the microvasculature. And the photo on the left is a control electron micrograph. It shows a swollen endothelial cell, as shown by the arrows. And the nucleus is not present in that particular picture. On the right is an electron micrograph of an SSO2 treated animal that shows normal appearing endothelium. It's thin, it's not swollen, and you see the nucleus is intact. This study by Spears measured absolute regional myocardial blood flow with microspheres in a canine model of coronary artery occlusion and reperfusion. In the normoxic reperfused group with the open circles, there was a deterioration of regional myocardial blood flow between 30 minutes to 120 minutes of reperfusion. And this really represents what happens with microvascular obstruction or no reflow. In the SSO2 treated group, shown in the closed blue circles, regional myocardial blood flow was significantly improved. And again, this tends to correlate with the findings in the previous slides, showing less microvascular ultrastructural damage with SSO2 therapy. Hence, reperfusion was improved at the microvascular level with SSO2. Now, while there's been some concern that supersaturated oxygen therapy has the potential to perhaps exacerbate the presence of oxygen-free radical damage, which is known to occur with ischemia and reperfusion injury, actually just the opposite occurred, as shown in this experimental study. Myeloperoxidase is a marker of oxidative stress and free radical damage. Myeloperoxidase was actually reduced with SSO2 and not increased in the heart, as shown by the yellow bar. Now, what is SSO2's likely mechanism of action? On the left, we show the following flow restoration with PCI. Capillaries can remain obstructed with endothelial edema present, blebs, activation of neutrophils, and other factors leading to microvascular obstruction. On the right, we see therapy with SSO2. What does this do? Well, the hyperoxemic levels of dissolved oxygen, which again can be 7 to 10 times normal values, provided by SSO2, allows for a high rate of diffusion of oxygen via the plasma, even before flow is fully restored downstream. The high oxygen levels have the potential to reduce endothelial swelling, preserve the microvasculature, and allow better restoration of microvascular flow and flow function. This slide shows the mechanisms by which SSO2 therapy reduces infarct size. Increased oxygen delivery by plasma, blood to the ischemic but viable tissue results in a decrease in microvascular damage, including reductions of edema, inflammation, local areas of coagulation, and reduced reactive oxygen species-mediated damage. This leads to increased regional myocardial blood flow and increased oxygen delivery to tissue with improved metabolism, decreased infarct size and apoptosis, and ultimately less left ventricular dilatation and less adverse left ventricular remodeling. Now, Dr. Greg Stone is going to discuss the clinical data for SSO2 therapy. Greg?
Well, great. Well, thank you, Bob. So this is a topic that I've been investigating for, over 3 decades now. So it's a pleasure to be able to give you my perspectives here. And while you're listening to this, please, everybody, use your remote system to be able to ask questions. And during the Q&A session, we'll try to get to all of them that have been submitted. So what I'd like to do now is go over some of the clinical data that we've learned that supports the potential utility of supersaturated oxygen in patients with large STEMI. So, I had mentioned before that primary PCI has really become the standard bearer for the efficient and effective treatment of patients with STEMI. And that was from original trials that we and others ran of randomized trials of primary PCI versus fibrinolytic therapy, showing decreased mortality, decreased heart failure, decreased rates of reinfarction and recurrent ischemia. And a lot of this was correlated with decreased infarct size. So if you want to really make the patient live longer and have less heart failure, the ultimate goal of reperfusion therapy is to turn what was going to be a large transmural infarct into a smaller, patchy subendocardial infarct, which will have less of an ultimate function on both systolic and diastolic left ventricular ejection fraction and function. So, for example, there have been studies that have been run, this is from the ISAR studies from Germany, looking at infarct size after stenting compared to TPA in this randomized trials, and you could see a substantial reduction in infarct size, and that correlated with reduced rates of death and death, reinfarction, or stroke. Now, we've done a series of large randomized trials, and as I mentioned, I'm often frustrated that we'll effectively reperfuse the artery, and we don't seem to have much of a benefit on left ventricular function, despite lauding ourselves for getting such high rates of epicardial patency. And this was from a trial called Horizons, which was a large-scale study. And we had an LV function sub-study in 656 patients where we had baseline left ventriculograms, that is right before the primary PCI in the acute phase of STEMI. And then we brought the patients back 13 months later. And you could see, if you look at the change in left ventricular ejection fraction, looked here on this cumulative frequency distribution curve, at baseline in red and at follow-up in blue, and then the overall change in LVEF from baseline to follow-up, you can see that the overall median change over that 13-month period was an ejection fraction improvement of 2%. But the interquartile range was very wide, going with 25% of the patients having a 6% or greater reduction in ejection fraction. In fact, you could think of it pretty simply that about 58% of the patients improved their ejection fraction, and about 42% of the patients had actual decrease in ejection fraction over time. And that's despite the fact that we had TIMI-3 flow restored in about 90% of the patients by this core lab analysis. So let me give you an example. I mean, I described that the greatest limitation today of primary PCI and STEMI is poor recovery of left ventricular function. So this was a 49-year-old man who was enrolled in Horizons, who presented with crushing chest pain for 90 minutes, typical time to presentation in the emergency room. And here's his baseline LAD. And you can see he's got total thrombotic occlusion of the proximal LAD before the first septal perforator. And here on the next slide is his baseline left ventriculogram before we open that LAD. And you can see acutely he's got complete akinesis to slight dyskinesis of the anterior wall, the apex, and the distal inferior wall. So a big wraparound LAD. So this poor young man is on his way to potentially having a huge infarct. So we had a very effective primary PCI. We had a door-to-balloon time of 67 minutes from the time he presented to the emergency room. And here's his post-PCI result. Here's the PCI 13 months later. And we restored TIMI-3 flow immediately after the PCI. And 13 months later, you can see the LAD is widely patent. You can see the stent in the proximal LAD. That's the most angiographically healthy appearing part of this artery right now. And there's TIMI-3 flow in this artery. So how did the patient do? Well, remember, here's his baseline left ventriculogram on the left, showing that potential large area of akinesis to slight dyskinesis. And here on the right is the 13-month left ventriculogram, which also shows that he had essentially no recovery of left ventricular function, and he's got what actually even looks like a thrombus in the apex of the left ventricle. So to understand the relationship between infarct size and outcomes, we performed a patient-level pooled analysis of 10 randomized trials and 2,632 patients in which infarct size was measured within 3 to 6 or 7 days, either by technetium-99 sestamibi or by cardiac magnetic resonance imaging. And we saw a graded relationship between the infarct size and death and heart failure hospitalization over a 1-year period. And you can see here about the average infarct size was around 18% absolute of left ventricular myocardium. And in the lower quartiles, those that had an infarct size of less than or equal to 8%, you can see almost no patients have death or heart failure hospitalization within 1 year. In contrast, the patients who had infarct sizes of greater than 30% of the left ventricle, and that was 25% of the population, despite having primary PCI, they've got about an 8 or 9-fold higher rate of death or heart failure hospitalization. And these studies all excluded patients with cardiogenic shock. So these are non-shock patients, anterior and non-anterior infarcts, all presenting within 12 hours, and strong greater relationship between infarct size on both death and heart failure hospitalizations. So again, why is this? Well, Dr. Kloner mentioned this concept of microvascular dysfunction. And even though we're very good at restoring epicardial coronary artery patency, the ultimate goal really is to get good blood flow to the myocardium and restore normal myocardial metabolism. And to do that, we need a myocardium that, one, might survive, that still is viable, and two, we've got to be able to restore microvascular blood flow to get the blood through the arteriolar system to the capillaries, so then you can have oxygen and nutrient exchange. And here you can see, for example, in the Horizons AMI trial, by core lab analysis, we have reperfusion success, that is epicardial TIMI3 flow restored in 86% of the patients. But if you look at evidence of myocardial blood flow, that is myocardial blush, this is normal in only 51% of the patients. And if you then look at our ability to stop ongoing myocardial injury, that is looking at ST segment elevation resolution, again, in only about half the patients are we actually stopping the infarct. So even though we get the infarct artery open, a lot of these cases, we're not getting the blood to the myocardium, and we're actually not having a successful PCI procedure. So I think we're successful in only about half of the cases, which is pretty depressing. So one of these problems has been mentioned now several times is microvascular obstruction. And again, the microvasculature can be blocked for multiple reasons. You saw the pathophysiology that Dr. Kloner showed. Thinking of it even more simply as a clinician, there can be thromboemboli, there can be neurohumeral induced vasospasm, there can be just massive destruction of the capillary system. And all of these reasons, on top of reperfusion injury from inflammation and reactive oxygen species that can be generated just from getting the infarct artery open, can lead to, again, total blockage of blood flow into the microcirculation. And one of the most direct ways that we can measure this is with cardiac MRI. And we can look at the area of late gadolinium enhancement to determine microvascular obstruction within 3 to 5 days or so after an infarct. And looking at this, approximately 2/3 of the patients will have some degree of microvascular obstruction. And we were able to show in the 7 primary PCI trials in which cardiac MRI did assess this, a graded relationship between the presence and extent of microvascular obstruction and mortality and heart failure hospitalization. The actual relationship between microvascular obstruction and infarct size is present, but it's only moderate. So actually, these are both important factors. And there are some very large infarcts that have very little microvascular obstruction. There's some infarcts that have large microvascular obstruction, but small infarcts. But for in majority, there's this relationship. The greater the microvascular obstruction, the greater the infarct size is going to be. And when we put all of this into a multivariable model, we actually find that all-cause mortality is predicted very strongly by both infarct size and by microvascular obstruction. Heart failure hospitalization predicted more by just infarct size, and microvascular obstruction didn't stay in that model. And this is the largest ever analysis. This is a patient level and individual patient data pooled analysis. And it really shows the prognostic importance of microvascular obstruction and infarct size, along with more common factors such as age and sex and delayed reperfusion time and baseline obstruction of the coronary artery. So you heard about supersaturated oxygen, in which we can deliver, again, an oxygenated hyperoxemic solution with a PO2 of 760 to 1,000 millimeters of mercury. And this was initially developed with a system in which we would actually put a catheter down the obstructed coronary artery. And most of the experiments have been done in the LAD, the left anterior descending artery, because the infarcts are about 2.5 times larger in the LAD compared to the right or the circ. So that's the area of greatest clinical need. And we would get the artery open, we would put in our stent, and then through this direct infusion catheter would infuse supersaturated oxygen for 90 minutes. And the beauty of supersaturated oxygen is it doesn't reduce door to balloon time. You don't have to do any of the procedures for it until you've opened the infarct artery and completed the stent procedure. And a series of randomized trials were run, first the AMI-HOT-1 and then the AMI-HOT-2 trial that I led, in a total of 300 patients with anterior infarcts, baseline reduced TIMI flow, reperfused by PCI with stenting within about 6 hours, and then randomize patients to either standard therapy or supersaturated oxygen for 90 minutes. And we were able to show in these trials, the first time ever in a pivotal randomized trial that was adequately powered, that we could reduce infarct size from about 25% in the control population, that's 25% or 1/4 of the entire left ventricular myocardium infarcted, to 18.5% with supersaturated oxygen. So that's an absolute 6.5% reduction in the amount of myocardium infarcted, p-value of 0.02, by Bayesian posterior probability, very, very likely to be a true finding. And this degree of infarct size reduction is consistent with about a 23 to 25% reduction in 6 month to 1 year mortality. Of course, we're not powered for clinical outcomes in this trial, but this is a very strong surrogate, that is infarct size to subsequent mortality. Now, the procedure was subsequently made safer with the development of so-called optimized supersaturated oxygen. And the way this works is that a draw line is used from the femoral artery, which draws blood into this hyperoxemic mixing chamber, which is then supersaturated, like through a bubbler, and then it is re-injected into the heart. But now in the optimized SSO2 delivery system, we're just injecting it into the origin of the left main coronary artery. So by not having to put a catheter into the left anterior descending artery, we've made the procedure safer. It infuses the SSO2 both in the circumflex and into the LAD. So it'll actually cause some vasodilatation in the circumflex as well as the LAD, and that may actually improve collateral flow. And again, it's a quicker and safer procedure. There's no chance that the infusion catheter is going to bump up and dislodge the stent, et cetera. And the safety of this was demonstrated in the so-called ICHOT study. This was a 100-patient registry that was designed in collaboration with FDA for the approval of this device. And it was really to just demonstrate safety. And the 30-day net adverse clinical events of any kind in these new 98 evaluable anterior infarcts was 7.1%, which was less than the performance goal that we had to met of 10.7%. And you can see, even though these were large anterior infarcts, there were no deaths. There was only one case of a reinfarction and a target vessel revascularization and a few minor bleeds. In fact, the target lesion failure rate, cardiac death, target vessel reinfarction, or clinically driven TLR, which is our usual composite efficacy outcome measure, was only one patient, 1%. So this was quite safe. And as a result, the FDA ended up approving this therapy. Now, none of these trials were approved for clinical outcomes, but I will say from this icy hot experience, we did a propensity score matched adjusted analysis of similar patients who were treated in another trial called Infuse AMI, which did not have supersaturated oxygen. And looking at the rates of death or new onset heart failure hospitalization, you could see that in Infuse AMI in a very well-matched population, this was 12%, whereas in icy hot after supersaturated oxygen, this was 0%. Now, again, we weren't powered for this. This is a highly statistically significant p-value of 0.001, but it's not a direct randomized comparison. But nonetheless, it goes along with what we would expect with the reduced infarct size. So the net effect was that on April 2nd of 2019, the FDA approved supersaturated oxygen therapy for the treatment of patients with anterior MI undergoing primary PCI within 6 hours of symptom onset. So this is really the first therapy that was ever demonstrated in a pivotal randomized trial to reduce infarct size that has now been approved for use in patients. So if I was going to summarize where we are with cardioprotection and infarct size reduction in STEMI, I'd say that primary PCI restores epicardial TIMI3 flow in about 90% of patients and reduces infarct size compared to fibrinolytic therapy, improving survival and reducing heart failure in STEMI. But nonetheless, despite successful primary PCI, myocardial salvage is frequently suboptimal, resulting in large infarctions with adverse LV remodeling, heart failure, and death. And again, the biggest two groups that we have to worry about are those patients who present in cardiogenic shock, for which SSO2 has not been studied, and anterior myocardial infarctions without shock, which is the other big risk group for which we've demonstrated a reduction in infarct size. So supersaturated oxygen is the first FDA-approved device-based therapy shown to safely reduce infarct size in a pivotal randomized trial. And again, that's anterior STEMI without shock, with decreased coronary blood flow, presenting within 6 hours prior to their primary PCI. So great. So let's look at what the results were now of the polling. Okay, so here was the first poll question. Infarct size is strongly associated with heart failure and hospitalization. 85% said strongly agree and 15% said agree. So I would give 100% of the people who responded credit with the right answer, because it certainly is associated with heart failure. In fact, it's really strongly associated with heart failure and hospitalization. From 10 prior studies, it's one of the best surrogates we have. And in fact, we even published secondarily that the change in infarct size is associated with a change or a differential in both mortality and heart failure hospitalization, which is really one of the advanced criteria for a surrogate. So I would say this has really been pretty well established. And infarct size is actually allowed by the CDRH, the device arm of the FDA, as an approval criteria for new devices based on this relationship. So let's go to the second poll question.
Bring up the second poll question. Okay, which of the following is true about microvascular obstruction in patients with acute myocardial infarction? And it looks like most of you got the answer right, about 75%. It is associated with larger infarct size and a worse prognosis, and that is the correct answer. And so I think Greg showed you the correlation between infarct size and microvascular obstruction, and there is a correlation such that the larger the microvascular obstruction or infarct size, the larger the opposite. So they do correlate with each other. And microvascular obstruction is associated with a worse prognosis. Now, some of that may be due to the fact that you're just associated with a larger infarct size. But also, when you have microvascular obstruction, it's associated with worse remodeling of the left ventricle. And some of that may occur independent of infarct size. So if you have an area of myocardium where blood flow cannot get in and blood flow cannot get out, it's a lot harder to remove necrotic debris if you don't have a route by which to do that. And that's what happens with microvascular obstruction. And then it's harder to get in the healings, the cells that are involved in the healing of the infarct if you have microvascular obstruction. So the healing phase is impeded by microvascular obstruction. That can lead to worse left ventricular remodeling, where you have a very thin scar. You have a regional dilatation of the left ventricle, and then you get global dilatation of the left ventricle, and that can contribute to certainly heart failure and death. B, it occurs infrequently is not correct. It occurs anywhere from 30 up to 60% of cases of ST elevation MI. C, it is caused only by distal thromboemboli is also not correct, because no reflow can be seen in models that are not even associated with thromboemboli, such as experimental animal models in which the coronary arteries are actually clean. And as we've shown by the electron micrographs, one of the problems is localized endothelial edema and these blebs. D, it is caused only by reperfusion injury. Well, some of these abnormalities in the microvasculature, the endothelial swelling, can be seen even before reperfusion. So the damage to the microvasculature actually starts during ischemia. Now, it may get worse during the reperfusion phase, and it may expand during the reperfusion phase, but there's clearly an element of damage due to ischemia as well as reperfusion. E, it is inconsequential. That's not correct. As I've shown you, and as Greg has shown you, microvascular obstruction is associated with larger infarcts, and again, with worse clinical outcome. Okay, let's go to the next question, number 3, which was, which of these therapies have been demonstrated clinically to reduce infarct size and acute myocardial infarction? Well, a lot of you put primary PCI, and that is correct. Primary PCI has been shown unquestionably to reduce infarct size, to be better than thrombolysis, and certainly better than no reperfusion. But B, SSO2 therapy is also correct and has been demonstrated, as Greg showed you in the MI-HOT studies, to significantly reduce myocardial infarct size. So the correct answer here is actually number E, which is primary PCI plus SSO2 therapy, or A and B. And some of you got that right, but not as many as I'd like to have seen. Let me just comment on post-conditioning, which is the condition in which you inflate and deflate the angioplasty balloon following initial reperfusion. That was shown in some experimental models to work. It never worked in our laboratory. We were never able to show that it reduced infarct size, although it did reduce arrhythmias. And the larger trials on post-conditioning, the larger clinical trials, were negative. Hypothermia in some of the large trials also did not significantly reduce infarct size when you looked at all comers, but there were some subgroups, such as in the COOL-MI study of Dr. Bill O'Neill, in a subgroup of patients who were reperfused within 6 hours and achieved a temperature of less than 35 degrees for anterior wall MIs, there was some reduction of infarct size. So there's still work being done in hypothermia, but the recent big clinical trials looking at all comers were negative.
So thanks, Bob. And it's really interesting that almost everybody knows that primary PCI reduces infarct size, but very few people were aware, at least prior to this webinar, of the fact that supersaturated oxygen, again, was shown in a pivotal, adequately powered randomized trial to reduce infarct size. And so I'm glad we're doing this presentation, because that's really important information to get out, as the patients with the greatest clinical need, those with anterior infarcts, who have large infarcts, really might benefit. So let's go for our last 15 minutes to some of the questions. And perhaps I'll take the first question. There's actually 2 questions that are kind of related, so I'll answer them together. One, would this therapy be appropriate for cardiogenic shock patients? And two, what other studies are planned for this therapy, and that therapy being supersaturated oxygen. So in the randomized trials and actually observational studies to date, cardiogenic shock was an exclusion criteria. Those patients are obviously very, very sick. Their coronary blood flow is reduced. The hemodynamic situation is so different that we really don't have safety or effectiveness data for supersaturated oxygen yet in those patients. So the therapy has really been approved for patients with anterior ST segment elevation myocardial infarction without shock that are reperfused within 6 hours. But that said, there is no reason to believe that it wouldn't be beneficial in shock. And in fact, we are hopeful that it would be safe and quite beneficial in shock, as those patients are likely to have much larger infarcts even. So there are actually 3 studies that are either ongoing or about to start with supersaturated oxygen, at least the 3 that I'm aware of. One of them is a pilot randomized trial in patients with cardiogenic shock called the ISO-SHOCK trial. It's just a 60-patient study. It's being led by Bill O'Neill in Michigan. And patients with shock, either STEMI or non-STEMI, and either left coronary artery or right coronary shock, are being randomized 1-to-1 to hyperoxemic blood, that is supersaturated oxygen, versus control after successful reperfusion and shock. And infarct size will be looked at by cardiac MRI, as well as the safety and clinical outcomes. And that's a very interesting study because no one's even looked at by MRI how big the infarcts are in patients who survive cardiogenic shock. So we're going to learn an awful lot from that study. In addition, there are 2 other studies that are ongoing. One is a second large randomized trial of supersaturated oxygen versus control, again in patients with anterior STEMI without cardiogenic shock. And this will be a little bit larger and will act than the prior studies that will be done, and actually has combined infarct size and clinical outcomes. So to really reinforce the clinical benefits of this therapy, as well as its safety now with the new optimized SSO2 approach. And finally, there'll also be a large registry among the new adoptive users of this therapy who don't want to participate for whatever reason in a randomized trial. So let's go to the next question. Bob, this one will be for you.
Okay.
What are the risks of the therapy, specifically as regards to oxygen-free radical mediated damage?
That's a very good question. I think a lot of people were concerned about the issue of oxygen radical damage, which we know does play a role in reperfusion injury. However, the experimental work from Dr. Spears and others showed that with the treatment of SSO2 in models of ischemia and reperfusion, there was actually a reduction in myeloperoxidase levels in the tissue, which actually suggests a decrease in oxygen radical mediated damage, which I think is really interesting. And I think that part of the reason that occurs is because the SSO2 is reducing ischemic damage during the phase where you've opened up the epicardial artery, but there's areas of patchy microvascular ischemia still present within that ischemic risk zone. And by reducing ischemia, you then reduce the presence of oxygen radicals when reperfusion takes place.
Great. Thanks, Bob. So here are a few more questions from the audience. Perhaps I'll take the first one and throw you the second one. So how do we know that the patient is having microvascular obstruction? Is it relating to risk factors or the amount of artery occlusion? Well, you can identify microvascular obstruction clinically either in the cath lab or post-cath lab. And in the cath lab, obviously, it would be the most useful time because then potentially you could do something about it. So the first time that you should suspect that there may be an issue with microvascular obstruction is if you're working on a patient with ST segment elevation MI and you've opened up the epicardial coronary artery and there's actually TIMI3 flow, there's no mechanical obstruction left, but the ST segments have not come down. So that tells you that there's ongoing myocardial injury. And it can be anything from the blood is not getting into the microcirculation, to the myocardial architecture is not extracting oxygen and restoring normal myocardial metabolism, i.e. the myofibrils are dead. So, but that tells you that you still have not done a successful primary PCI. And probably at least 50% of patients don't have complete ST segment resolution after primary PCI. So we're not as good in the lab as we think we are. We can look at myocardial blush. Myocardial blush is looking at the wash in and wash out rates of the blood flow into the myocardium itself. Think of the myocardium as a sponge, and you're kind of looking at the ground glass appearance of that sponge is basically a diffuse haze of contrast getting in and then getting out. That can be hard and very subtle, but people who know what they're looking for can be trained to look at myocardial blush. And then finally, in the cath lab, there's physiologic measures that people are very interested in looking at. Initially, coronary flow velocity or reserve, but more recently, the IMR, index of microcirculatory or myocardial resistance, and other similar parameters where you can actually measure in the microcirculation if there is residual resistance, which can represent microvascular obstruction. Post-cath lab, the best way to recognize it is usually with cardiac MRI, done between 3 and 5 days with late gadolinium enhancement, which is been clearly demonstrated to reflect microvascular obstruction, but then it's probably too late to do anything about it. So Bob, let me give you the next question. What about the role of adenosine while performing primary PCI in helping reduce endothelial swelling or any other benefits it might have?
Right. There have been some experimental studies and other studies with adenosine suggesting that it may reduce no reflow to some extent. The story on adenosine and myocardial infarction in the clinical realm has been somewhat mixed. So there are studies that both you and I have been involved in, with the Amistad studies, which actually did show that if adenosine was given as an IV infusion, started prior to reperfusion, continued for 3 hours, that it would reduce myocardial infarct size for anterior infarcts. It did have some deleterious effects, however, in inferior infarcts. And in some studies where adenosine was given directly down the coronary artery for shorter periods of time, it did not seem to have a benefit. And I think part of the problem there is that adenosine has a very short half-life. So if you're going to give adenosine, it really has to be given as an infusion over a period of time to see a benefit.
Okay. And it never really caught on. And it needed
no, it didn't.
More major trial to prove its utility, and that was never done.
Right.
So we have a good question. This is a really good question. Can you use high flow oxygen instead of a supersaturated oxygen delivery? And the answer is clearly no. Yeah. So high flow oxygen at best will, let's say, even a patient who's intubated and on 100% FiO2 will get you a PaO2 in the oxygenated blood of maybe, the highest 100 millimeters of mercury. So what we're talking about with supersaturated oxygen is bringing up the PO2 of blood to 760 to 1,000 millimeters of mercury. And you're actually infusing the blood, you're actually preparing the SSO2 hyperoxemic infusate under high pressure to be able to get those kinds of oxygen concentrations. It's like putting the patient into a hyperbaric chamber. And actually hyperbaric chambers, which of course are used for wound healing to try to get ultra high tissue levels of oxygen. In the early phases of myocardial infarction, 4 decades ago, actually, people explored hyperbaric oxygen chambers for patients with STEMI. And there were some anecdotes that it worked, but that's not a very practical therapy for patients with STEMI. A much easier and more direct way is to use SSO2, which gets you to the same effect, but obviously in a much safer and more convenient fashion. I don't know, Bob, if you want to add to that.
No, I agree with that.
Great. And then let's see, we may have one last question, and that is that I can answer quickly. And, you know, well, actually, I have two other questions. I'll give you this one, Bob. This is indicated for patients who present within 6 hours of symptom onset. What does that mean? What symptoms are those 6 hours?
Well, we're really talking about the symptoms of acute ST elevation MI, where there's a crescendo, basically increase in chest pain, usually seen over 6 hours. We're not talking so much about patients with who may have unstable angina, where they have episodes of chest pain that come and go. We're really talking about the symptoms of acute myocardial infarction.
Great. And then very last, I'll answer this one very quickly. What do you do? It's a 60-minute post-PCI infusion. What do you do for the patient who comes in at 2 a.m.? And, you know, the point is, this is a potentially life-saving therapy for patients who really have large infarcts. To be able to reduce the infarct size by more than 5% of the absolute left ventricular mass of the myocardium is substantial. And for 60 minutes, it's worth it, whether it's 2 a.m. or 2 p.m. for patients with truly large infarcts. And again, the catheter is just sitting in the left main coronary artery. The physician doesn't need to stay scrubbed as long as there's a rotating nurse that's keeping, or technician keeping an eye on the patient. The physician can go speak to the family, can write his or her notes, and can do other business. He or she should stay close to the cath lab, of course, until that 60-minute period is over. But again, this can be done in any cath lab with any team that can do the primary PCI procedure with 2 or 3 people. You can easily administer the SSO2. So we're out of time. I hope that everybody has enjoyed watching this as much as Bob and I have enjoyed putting it on. We, again, both of us in varied ways have been trying to improve outcomes for patients with STEMI for, again, 3 to 4 decades. Bob, we're giving away our ages, but I guess that's okay because we're finally making some headway. And reperfusion therapy was, again, the major progress forward, then primary PCI over fibrinolytic therapy. And now the last 2 real holy grail areas are reducing infarct size and managing patients with cardiogenic shock. And I think with supersaturated oxygen therapy, we've made our first headway into at least minimizing infarct size in patients with large anterior myocardial infarction. So thanks, everybody.
One last point. We do want to mention that this webinar has been supported by Zoll. So thank you very much. And thank you to the audience for listening in. And Greg, thank you, and have a good rest of the day.
Bye, everyone.